above the GE junction is type 1, above 1 centimeter, below 2 centimeters type 2. And these two, that is the type 1 and 2 is now being included in the esophageal carcinomas, while 2 to 5 centimeters type 3 is being included under gastric. Alright, so now we, so something important to know.
Rakesh, sorry.
Notes, 2 screens are there, no? Notes.
Yeah, that is just whatever extra I wanted to sort of add, because as I told you, this was just a made for.
The main screen is like shorter and notes one is bigger. So
you want the main screen bigger? Okay, I'll do that for a second. Yeah.
Okay, Rakesh, thank you.
Better. Thank you.
Yeah, one moment. No. Yeah. Anything important here? Yeah, no, we'll come to that. No, I was doing that because I was using it. So anyhow, okay. Not very sure about iPad. Yeah. So the esophagus, and a very important thing to note is it doesn't have a serosa. So the local extension can be pretty, pretty much more than any other part in the GIT. So the local extension can go to the thyroid, trachea, larynx, lung, pericardium, aorta, and diaphragm. There are two lymphatic plexuses, mucosal and muscular. So that in this lymphatic plexus, the spread generally they say upper 2/3 is upwards and lower 1/3 is downwards. But easier or more safer to mention is upper 1/3 usually the direction of flow is upward, lower 1/3 is downward, and the middle can go either direction. So because in two places I saw that it can vary. And if they ask you, okay, fine. Like I'm covering both theory and practical. Okay, so just as a conversation, because my boss Vijay Kumar sir usually takes everything as a practical exam. So even when I presented this, whatever came up in our presentation in class, I'm bringing it here. So he asked a question about in how many percentage of cases can this deviate? So the answer I found out from some literature search is 30%. So anybody asks you, it is about 30% where this deviation can be seen. In the sense, in upper third esophageal tumor also, you see lymph nodes happening probably in the abdominal sites and vice versa. So 30% cases a deviation can be seen. Hematogenous spread, liver being more common, lungs, bones further ahead. ठीक है, मेटास्टैटिक स्प्रेड में लिवर ज्यादा होता है फ्रॉम esophagus. हाँ, तो etiology के पहले I just want to go again to the anatomy. Sorry, I'll keep doing this because obviously I'm not prepared too well. I want to show the picture. So ठीक है, so this lymph nodal stations is something important for us to know here, anatomy wise, because now as you know the dissection being told to be more radical than earlier what was being practiced. So 101 onwards. So this is the Japanese classification, just for you to really understand. So we have a 1 to 13 or even more actually, etc. in the stomach, right? I think last class actually I didn't completely attend. So okay, he must have discussed it, I'm sure. But now for the mediastinal channel and the cervical part of it, 101 being cervical, paraesophageal. All of these has left and right, okay? And 2 deep cervical, 4 being supraclavicular. So there are two things that I've seen. I'm not sure which one to follow. Anybody has any input on this? I saw one where 1 is written as superficial cervical and 2 being cervical paraesophageal, while in another place it is written 1 as cervical paraesophageal and 2 as deep cervical. So I'm not sure which one to follow. But just, if you guys have any input. This is what I found to be a better source since it was from Sugar Baker's paper.
That another one is for lung, I think.
Is it? Okay, so wow, great. So there's even more for the lymph node stations. Anyway, we'll follow this for now. So cervical paraesophageal is 1, 2 deep cervical, 4 supraclavicular, 5 is upper thoracic, then the 6. So 6 dissection is said to be very important these days, recurrent laryngeal nerve. Then the left tracheobronchial is also there. Then 7 subcarinal, 8 is middle thoracic, 9 main bronchus. I hope all of you can see this, right? 10 lower thoracic paraesophageal, 11 supradiaphragmatic, and 12 posterior mediastinal. I'll share all of this in the group or however we are sharing now, so that you guys can also look at it again. A little difficult to really figure out otherwise in one shot. So this, it has been asked to us in our classes, so better go through this also. So coming back, now to the etiology of things. In the meanwhile, I also want to mention some other points that I have read. What if anybody asks you is the normal thickness of an esophagus? it is less than 3 mm. Okay, so even in a distended state, like when food is there or liquid is there, it should not exceed more than 3 mm. So in the CT and all that, when a thickness is seen more than 5 mm, it is considered abnormal. Besides this, yeah, I think everything else in anatomy we have covered pretty much. Okay? Yeah, so moving on, etiological factors. Okay, this again just drama. So the more significant thing is this one. So both of these, okay, if you go through like literature or you go through some classes, you'll see that even though we ultimately treat squamous cell carcinoma and adenocarcinoma to the same extent, like almost similar management, everything else varies for the two of them in esophagus. Okay, so etiological factors, sometimes even the clinical presentation varies. And you know about the trials, cross-imaging and all that for the pre-op treatment. Otherwise, surgeons-wise, generally we tend to think that isme kya hai, SCC, adeno, same hi to hai. But this one slide sort of shows you the difference, where there's a lot of difference between the etiological factors. Squamous cell carcinoma mein very prevalently cigarette smoking, alcohol drinking, and very hot liquids, achalasia cardia, thoracic radiation, tylosis, all this has a lot of effect in the etiology. While on the other hand, for adenocarcinoma, it's usually those pre-malignant lesions caused by, say, GERD, Barrett's esophagus, obesity being a factor for all of this, sometimes even cigarette smoking. Something to note here is alcohol has predominantly been found to have no relation to adenocarcinoma. So if some trick question, somebody asks something, cigarette smoking, alcohol, yes. For SCC, cigarette smoking for adenocarcinoma, yes. Alcohol, no for adenocarcinoma. Otherwise, the usual diet and all that is there. Processed meat, low in fruit and vegetables, etc. So, yeah, these are independent risk factors for squamous cell carcinoma. Synergistic effect. Again, this is just for Vijay Kumar sir's this thing. He has very, very important. So, in just a point to you guys, if at all he comes, he might ask about relative risk of most of the etiological factors. It's something he loves to ask. So that is why I have put that there. So how does alcohol come across as a etiological factor? These are the different mechanisms told. One, it acts as a solvent for these carcinogens. So that's why the synergistic effect comes with smoking. So that is solvent of fat-soluble components. It is a mechanical irritant in itself. Promoter of dietary deficiencies. Like people who tend to drink a lot sometimes don't eat good food either, and tend to thus have a dietary deficiency too. Cellular DNA damage directly by the acetaldehyde DNA adducts, thus causing mutations, and decreased metabolic activity, thus reduced detoxification. So whatever toxins are entering your body are not getting detoxified well enough. Okay, so some points to note for the mechanism in which alcohol acts as an etiological factor. There is a dose-response effect seen in squamous cell carcinoma about the amount of alcohol ingested, the duration and intensity of smoking. But here it is written, right? Not in adenocarcinoma. So something again peculiar is, even though smoking cessation, that is stopping smoking, has an inverse relationship with the risk factor for SCC, it has been found that for adenocarcinoma, this does not exist. So that might be because in adeno, once the tobacco carcinogen is affecting you, that is a very early effect, the effect stays the same. So once you stop smoking, the risk of that person's getting adenocarcinoma does not actually go down, unlike in squamous cell, where usually how you will expect it to go down, it does go down in a good inverse relationship. Diet, low fruits and vegetables, micronutrient deficiency causes low antioxidants and thus does help in the pathogenesis for SCC. Diet-derived carcinogens, especially in meat, we have nitrosamines, burning of wood and coal causing polyaromatic hydrocarbons, and pickled vegetables and nitrosamines, yeast and fungi having mycotoxins, hot beverages causing thermal damage. All this is for SCC. Okay. Now we move on to adeno, and so in this regard, there was something here for me to tell you guys. So something I read in NCCN guidelines was that in general, squamous cell carcinoma tends to localize at a level at or higher than the tracheal bifurcation. That's why I think maybe you can see, many of the cases we have a lot of issues where the trachea is all adherent and especially post CTRT. So just try to remember it like that. SCC does have a predominant location being at or higher than the tracheal bifurcation. It has a proclivity for earlier lymphatic spread and is associated with a poorer prognosis. The reference for this is NCCN guidelines. Okay. Then, take it. So adenocarcinoma, high body mass index has been established as the strongest risk factor for adenocarcinoma, Meta-analysis found that BMI more than or equal to 30 kilogram per meter square had a higher relative risk as compared to those below 30. How it develops is basically higher BMI, that is obesity, causes GERD, which is an underlying cause for adenocarcinoma. It causes Barrett's esophagus, which is a precancerous condition. What is Barrett's? Normal squamous epithelium esophagus damaged, causing it to turn metaplasia to columnar or glandular epithelium. There is 30 to 60 times, 30 to 60 times greater risk of developing adenocarcinoma than the general population. So these are some of the factors that NCCN mentions for higher risk, which is older age, male gender, long-standing GERD, a hiatal hernial large size, as well as length of Barrett's esophagus. How much of the esophagus is has developed Barrett's? How much of a hernial orifice larging, that is hiatal hernia, has developed? Long-standing GERD, male gender, older age. These are all associated with higher grades of dysplasia and thus increased risk of esophageal adenocarcinoma. Just to mention, hereditary cancer predisposition syndromes do exist even for esophagus. That is the tylosis, that palmoplantar fibrosis. Familial Barrett's does exist, Bloom syndrome, and Fanconi's anemia. Okay, so sorry. So yeah, this we've already mentioned. There is a difference between whether a person has daily symptoms or weekly symptoms. That also gives you a clue according to the risk for adenocarcinoma. H. pylori, on the other hand, has an inverse association, because what happens with H. pylori is you have atrophic gastritis. So you have a reduced acid and thus the ulta, exact opposite of GERD happening. So if a person has H. pylori infection, actually their risk is lesser for getting adenocarcinoma. ये सब हो गया, ठीक है? Yeah, clinical presentation कुछ है नहीं. Dysphagia usual, as you know, it is usually progressive, initially to solids and then to liquids. Weight loss, retrosternal pain, they can develop cough, hoarseness as the disease increases in terms of aspiration, etc., as well as the involvement of the nerve, recurrent laryngeal nerve, bony pains, backaches, bleeding, all that usual. Staging, you want to take over, or how is it meant, Soundya? I mean, I have something prepared, but
you carry you carry on whatever you have.
Carry on,
discuss somewhere else together, esophagus, stomach, and colon, rectum, everything.
Okay. So we have our staging. Obviously, the workup for the patient with esophagus that is presenting with dysphagia, usually with weight loss, etc., would be go ahead with a UGI scopy. What do you get? What are the important things to get? Extent and skip lesions. I wanted to mention something that Sir had one mentioned in one of the classes. So I think you all know Akiyama, right? His papers were very key in everything, treatment and diagnosis, everything of esophagus. So he has some studies. So Sir once asked the question, how is the margins determined? How do you determine that you need this much margin and this much margin proximally and distally? So that is through his study. His study showed that skip nodules longitudinally, that is within the length of the esophagus, skip nodules can develop up to some centimeters. So that is how we have determined this margin. And the margin determined is 5 centimeters distally and 9 centimeters proximally. Tum cut loge to your local recurrences low. I haven't actually gone back and read this again nor seen the study. If any of you can share it in the group, that would be wonderful. But he said that there's a study by Akiyama which showed this. That is how this, that's how, for cervical esophagus. So the question I think how he had asked was cervical esophagus mein hum kyun nahi karte hain esophagectomy? Like you can get a small margin, no? What is the big deal? Of distal gastrectomy, you can just get minimal margin. So this was the answer to that. Okay, so that came up because of the skip lesions. Okay, biopsy obviously lena hai at least 6 to 8. If somebody asks you, kya bolte hain? Bits. Okay, 6 to 8 biopsy bits should be taken using a large size endoscopy for sufficient material. Okay. What have I written here? ये सब मैं NCCN से उठा के just copy paste किया अभी as I was reading. तो इधर, okay, I'm reading from here if you guys can read that. Now, survival analysis has found that increasing obviously anatomic tumor size and depth, that is as the T increases, as the N increases, as the M increases, and the histologic grade and advancing age. These are the prognostic markers for esophagus. If you really want to think about it, TNM, grade and age. Easy. And they also found that survival increased with more distal location of cancer within the esophagus. So more distal the tumor location, survival was better. Then, so now we come on to the investigations, the staging per se. So the best accuracy for T staging is by EUS. Okay, and it is the only method by which we can actually delineate. Oh, I didn't really tell you guys about what the TNM is, right? कोई बात नहीं. ठीक है. Anyway, it's very simple TNM for esophagus. I'm sure all of you know that. So T is what? T is up to the submucosa, but not involving the muscularis. So invading up to the submucosa is T1. T2 is invading muscularis mucosa. I'm sorry, muscularis propria. I'm continuously saying mucosa. My bad. T2 is invading muscularis propria. T3 is adventitia, and T4 is the adjacent structures which have been divided. Obviously, the things you can remove under T4A, easier to remember that way. Removable or operable structures, resectable structures, pleura, pericardium, azygous vein, diaphragm, peritoneum. T4B being the unresectable or inoperable, aorta, vertebral body, airway. Okay, so this it's happening. Okay, I'm also having some learning curve with iPad people, so please not hate here. Yeah. So as I was saying, locoregional staging mein best accuracy is with US for T, and it is the only method capable of delineating these layers. So this, as you can imagine, if you have to really differentiate between this muscularis propria involvement and all that, it is a bit tough otherwise. So EUS is the only thing that can really differentiate between T2, T3 and T4, T2 and T3 especially. Alright, now, however, early stage, that is T1A, oh yeah, so I didn't really mention T1A and T1B. So there's a T1A and a T1B, as you can see here. T1A is lamina propria or muscularis mucosa, and T1B is submucosa. Now, once we come to the treatment in another class, that time you'll know why I'm specifying this. Between T1A and T1B, we will not be able to differentiate with EUS. It is not very accurate. So that's why they actually go ahead with the, actually it is endoscopic resection, and then they decide the T staging for that. So that is one point to remember if somebody asks you. Otherwise, T best hai EUS se. Nodal best is with EUS with FNE, but of course, generally we do a CT scan. So generally, if somebody asks you what the NCCN guidelines suggest to do, it is CT, contrast enhanced CT of thorax and abdomen with the pelvis clearance, with the neck also screened, is what is best. But is what is done. But what is best पूछेंगे तो EUS for T, EUS with FNA for nodes, and for metastatic, now it has been found that FDG PET CT is more sensitive than CT alone for the metastatic, what do you say, workup. ठीक है, anything else here? हाँ, तो ये भी है, परसेंटेज वगैरह पूछेंगे तो 85% accuracy है T के लिए, 75% for nodal with EUS, okay, and 85 to 100% with FNA when you combine. However, there is an overstaging that can happen because of the fibrosis after a pre-op CTRT being done. So that is one pitfall for EUS. CT chest and abdomen has an accuracy almost of 100% for METs, but not for T or N. FDG PET is better for metastatic. Think, yeah, just a photo for you guys to see that whole T1A, T1B and all that. T4. I think I'm done here. As far as I've prepared.
Little bit they are going towards that. Even they can differentiate between those early lesions.
Involvement में कुछ तो I wanted to ask actually because I saw it in that class, this ISO wala. This aorta involvement being divided as less than 45, 45 to 90, more than 90. उसमें कुछ नाम है?
Picus angle is there. Picus angle.
What? Sorry?
Picus angle is there.
Picus angle.
Yeah.
हाँ, ठीक है. So that, yeah, that is a mention too. So the involvement in the
PICUS picus angle.
हाँ, picus angle.
PI से जो आपने बोला वही है.
हाँ, less than 45 degree है तो
आप शेयर करना शुरू करिए ना.
क्या?
Treatment options and the various controversial topics associated with PNET. So, as a short introduction, it accounts to 3% of the pancreatic neoplasm and 7% of the neuroendocrine on the clinical symptoms, because PNET with increased heart rate, if there are no clinical symptoms, then they are not considered functional. So more than 2/3 of the pancreatic NETs are non-functional. Functional will be insulinomas, gastrinomas, glucagonomas, VIPomas, and stomatostatinomas. With the 95% of the PNET being sporadic, only 5% are hereditary, which will be associated with MEN1, PHL, NF1, tuberous sclerosis, and Carnegie sporadic NET, no known etiology, and the mean age is around 60 years with 60% metastatic at the time of diagnosis. Increased incidence is seen in recent years because of the increased imaging, and the median survival for grade 1 and grade 2 is almost 42 months. This is including everything, but when they're localized to the pancreas, the survival is almost 136 months. When they present with nodal mets, the survival is 77 months. And 64% of the patient's hospital is present with distant mets. In that case, the survival comes down to 24 months. So if you have to classify pancreatic neuroendocrine tumor, we can divide them into well-differentiated and poorly differentiated. The well-differentiated are known as neuroendocrine tumors, while poorly differentiated are called as neuroendocrine carcinomas. So neuroendocrine tumors have less cellular OTPia, no or patchy necrosis and blood vessels on histology, while neuroendocrine carcinoma has in the duodenum and bile duct, which is important here, and T4 when the adjacent structures are involved. So the clinical features of non-functional, they're usually asymptomatic until and unless they're large enough to cause local compression, or they have to present because of the metastasis, like causing abdominal pain, distension, obstructive jaundice, or gastric outlet obstruction. While for functional, it depends on the a peptide that has been synthesis. This I'll be sharing. I think we all can go through what are the symptoms associated with each one of them. Diagnosis, most important is the CCT because they are usually hypervascular. They're seen as hyperdense lesion during the arterial phase. So much that even if liver mets are present, they are also seen as hypervascular lesions. And a differential diagnosis to this is a hypervascular mass, which is seen in the tail of the pancreas, can be an intrapancreatic accessory splenic tissue. So it is very, very rare. This was mentioned in Davita, so I just thought I'll mention it here. For assessment of resectability for an PNET is very much similar to the criteria that we follow in a pancreatic ductal adenocarcinoma. And the sensitivity of CT is almost 73% with specificity of 96%. In case of liver mets secondary to NET, the sensitivity is 82% and specificity is 92%. The role of MRI is more in liver mets because it is better than CT with a sensitivity of 93% and specificity of 88%. The other images are US. It is useful when the lesions are very small, like 2 to 5 mm. In that case, the detection rate is almost 90%, and also we can take a FNSE or a core biopsy US guided. The next one, which is special to this, is the functional imaging status. This is based on the principle that 70% of the PNETs express high level of somatostatin receptors. So that's why we use somatostatin receptor scintigraphy over here. It is a recent days even hybrid imaging modalities where we combine PET-CT with somatostatin analogs like 68 gallium SSA or 18F DOPA scans are used. But one thing here is whenever there is increasing proliferation, that is the higher Ki67 level, the somatostatin receptor expression decreases. And therefore, these tumors won't take up uptake. We don't see any uptake on SRS. So in such cases, PET-CT has a role. Hence, both these methods are complementary, especially when we are diagnosing a higher grade NET or a NEC where the Ki67 level is more than 20%. So, and an increased FDG uptake also indicates that there is loss of differentiation with a higher grade tumor, and it also tells that it has an adverse biological behavior. So, the present role of somatostatin receptor imaging beyond this was for the what we discussed was for the diagnosis. Other than for diagnosis, it is used in the detection of a recurrent NET in follow-up cases of gastroentero pancreatic NETs and in patients of monitoring when the extent of the disease cannot be relied on the conventional imaging. Next is the serum tumor marker. All the tumor markers are measured in a fasting state. I've mentioned only the three important ones. There are various others. Most important being the chromogranin. There's one of the study, Radiant 1 study, where they saw that when there was response to the therapy, 30% decrease in the chromogranin A level was noted in 4 weeks. And it was also associated with increased progression-free survival. Other two which are important tumor markers are neuron-specific analysis and pancreatic polypeptide. So what's the role of tissue diagnosis? It helps us to assess the status of endocrine differentiation and also to evaluate the prognostication. But we don't need to have a tissue diagnosis always. We can avoid if the dotatate PET is clearly positive, or if the lesion is less than 2 centimeter, because these are usually well differentiated, and a localized PNET, or if you're planning for an observation or an upfront surgery, in that case we can skip the tissue diagnosis. And if at all we are doing, then core is better than FNA. And in pancreas, to do a core, of course, the expertise is required. In that case, even FNA is okay. But if it's a metastatic site, then always core biopsy is better. So this is the same thing to discuss. The mitotic count and the Ki67 level as per the case. So treatment, it's multidisciplinary. Surgery is the only curative strategy in PNET. Treatment for liver mets can include TACE, TARE, liver ablation therapies, and medical treatment will include somatostatin analogs, interferon alpha, chemotherapy, targeted therapy like everolimus, sunitinib, or PRR. So surgical management is known to be curative. Aggressive resection has shown to improve overall survival. Cytoreductive surgery has been recommended for control of secretion of activated hormones and improvement of survival in case of advanced PNET. One more thing is whenever it's a functional tumor, all functional tumor, irrespective of the size, treatment is resection, and a non-functional, which is more than 2 centimeter, resection is advised. So what about non-functional, which is less than 2 centimeter? They have limited metastatic potential. So this is from NANET 2020, where they have again classified it into asymptomatic. These are usually asymptomatic into less than 1 centimeter and 1 to 2 centimeter. So if they're less than 1 centimeter, we can observe, and biopsy is not necessary to confirm for the diagnosis. Since we have already we are observing, we can just keep at a regular follow-up. For 1 to 2 centimeter, we can either observe or we can resect. This option needs to be individualized based on various criteria like age. If the patient is an elderly, we can as well observe rather than doing a surgery, because these are known to have a very good overall survival even when it is observed. So patient with multiple comorbidities, we can observe rather than resect. If the tumor growth over time is high, in that case we can resect. So like that, we can decide on the various factors like estimated risk of symptom development, grade of the disease, extent of the surgical resection that is required if at all we are resecting, what are the patient wishes, and how is the SS to long-term follow-up. The patient is coming from a very much interior place, he might not be able to come for every 3-month follow-up. In that case, if surgery is not extensive, in that case we can opt for resection. So while in case of functional tumors, we need to first classify into which functional endocrine syndrome it fits into. And most of these are associated with MEN1. So we have to rule out MEN1. Staging needs to be done to rule out distinct mets, grading, and risk of malignancy. Insulinoma, only 5 to 15% are malignant. But when it is a gastronoma, gluconoma, or BIPoma, there are 60 to 90% of the times of them being malignant. So there is biochemical cure rate and there is recurrence. So when it is a localized insulinoma, the chances of getting a biochemical cure rate is 98% and the recurrence rate being 6% at 10 years. While for sporadic gastronoma, the cure rate might be 60% immediately after resection, but after 5 years it drops down to 30 to 40%, and 15% is the 15-year PFS. When we are not able to localize a functional NET, previously blind resections were followed, but nowadays with improved Rotenov scan and localization techniques like US and SRS, blind resections are no longer acceptable. what are the various controversies we come across in the surgical management? One, when should the enucleation be employed in PNET? So enucleation is used when we want to preserve the endocrine and exocrine function. So in that case, we want to do a parenchyma sparing surgery, but it also comes with a cost of higher post-operative pancreatic fistula. So it is reserved for very small tumors and tumors which are more likely to display a benign behavior like insulinomas or non-functional PNETs of 2 to 3 mm, which are at least 2 to 3 mm from the main pancreatic duct, so that the chances of POPF is less. So, what type of margin is considered adequate for PNET resection and for enucleation? The goal is to achieve a negative margin. There is no data to support the more aggressive resection, the more wider surgical margins as well. So, what is the role of central pancreatectomy? Indication for central pancreatectomy is when it is a small, low-grade PNET in the neck or body of the pancreas that cannot be enucleated because it is very close to the MPD, or left pancreatic remnant is long enough to maintain the sufficient pancreatic function. So we don't have to do a long left this thing resection, so we can preserve the pancreatic parenchyma. In those cases, we go ahead with central pancreatectomy. But patients who have larger lesions, who have diffuse pancreatitis or high-grade malignant tumors, these are not suitable for central pancreatectomy. Advantage is again it preserves the pancreatic parenchyma, thereby endocrine and exocrine function is preserved, but it is associated with overall morbidity and risk of POP. What is the adequate lymph node dissection in PNET? This is in NANET 2020. They are given as formal surgical resection or like removal of 11 to 15 nodes. But when I was discussing it in our department, they said there's nothing like you have to remove so much of the lymph nodes. When you're doing the resection, whatever lymph nodes comes along with it, that is the standard. And until and unless there's some lymph node that is seen as showing uptake in a preoperative imaging, that needs to be removed. So, but in NANET, they had given removal of 11 to 15 lymph nodes, and if you're doing a pancreas sparing surgery, like in case of smaller NET, like enucleation or anything, then the suspicious nodes needs to be removed. Hepatic cytoreduction, whether it can be performed when there is a pancreatic neuroendocrine tumor with liver mets. The extent of cytoreduction that we do has shown little difference in the PFS or OS. Once more than 70% of the cytoreduction has been hit. So it needs to be individualized based on number or distribution of the lesions, patient's age and comorbidities, rate and rate of progression. So this is still controversial. There's no clear-cut consensus on this. So, is it safe to perform a concurrent ablation and resection of the hepatic metastasis when we are performing a Whipple's? So, what most of the studies have shown that retrospective data that whenever there is a biliary enteric anastomosis, like an HA, the risk of liver abscess is more. So, Whipple's and the liver treatment simultaneously, if it is done, then in that case it reduces the risk of liver abscess, or rather than doing a Whipple's first and liver therapy later. So, or we can do a liver directed therapy first and then plan for the surgery, so thereby reducing the risk of liver abscess. So, is there a benefit of resecting the primary tumor when there is an unresectable metastatic disease? No consensus on this, but various factors based on the individual cases, like if the tumor is a functional tumor, then we might at least reduce the bulk of the tumor, and thereby symptoms might reduce for the patient. And then for the unresectable metastatic disease, we can plan for PRRT, or the location of the tumor is in the tail or body, so the surgery is not so morbid as much as doing a Whipple's procedure. In those cases, we can resect the primary. If a patient is elderly or multiple comorbidities, so the risk of the surgery is more, then there's no point doing the surgery. So, and when we reduce the tumor bulk, the possibility to improve the response for PRRT also increases. So, if there is an extrahepatic disease, whether it is a contraindication for removing the primary tumor or doing a hepatic cytoreduction, so this decision to resect the primary should be based on how much will be the local complications because of the surgery, how severe is the symptoms the patient is having, and to improve the response. Like for response for PRRT is better when the downstage the disease. So extrahepatic disease is rarely the cause of death in PNET. So it's presence should not necessarily be a contraindication. This was about the primary surgical treatment. For the treatment for the liver metastasis, resection is the first choice if it is resectable. Otherwise, it is TACE, TARE, thermal ablations are the other options. Liver transplantation has also been successfully used. So, but these are in very highly selected patients, like resected primary with no extrahepatic disease, well differentiated NET with a low Ki67 index, basically meaning a good biology tumor, having demonstrated at least 6 months of the disease stability, 6 months of disease stability before doing a liver transplantation. All these indicate basically it's a good biology tumor. So these are the patients who are selected for liver transplantation. So in case of advanced PNET, various medical management like somatostatin analogs, octreotide and lanreotide are the ones that are approved over here. Octreotide is approved for the control of symptoms related to hormonal hypersecretion. This trial is important, Clarinet trial, where it was an RCT, lanreotide 120 mg was compared with placebo. They saw that there was significant increase in PFS whenever lanreotide was used. But the control arm where the placebo was used, even that patient has a progression-free survival of 1 year. It's because the most of the patients that we used were the ones with a stable disease. Chemotherapy, various regimes, most commonly used is a streptozotocin and doxorubicin because a PFS of 20 months was noted in these. Others are temozolomide or temozolomide with capecitabine. Everolimus is more in genetic mutations in tuberous sclerosis type 2 and NF1. There is activation of the mTOR pathway. So even in sporadic PNETs also there is activation. So this pathway is inhibited by the everolimus. So two more studies which showed this was in Radiant 1. Advanced PNETs who progressed when they were on chemo were randomized into receiving everolimus and one more group into receiving everolimus and octreotide. And they found that the PFS was better in everolimus plus octreotide group. So even with the Radiant 3 is another study in progressive PNETs, they studied everolimus versus placebo. So the other targeted therapies are sunitinib, sorafenib, which have shown to improve the PFS. Next is the PRRT. The study is important, NECTAR-1, which has showed that there is progression-free survival benefit in the PRRT arm, especially among patients who had mid-cut NETs. So one more study is Erasmus. So because of NECTAR-1 and Erasmus, FDA has approved lutetium-177 dotatate for PNETs. So this was about this thing, sporadic, but for family PNET, a few things. So family PNET, the broad principles that we have to follow is one, we have to go for the parenchyma sparing operations over here and preserve the endocrine and exocrine functions because these are usually multifocal. So we remove the dominant lesion now, but there might be spumo lesions which might come out later. So parenchyma sparing operations are preferred over here. And if it is a low risk tumor, as well a watchful surveillance is enough. But for an intermediate risk tumor, enucleation or minimal pancreatic resection needs to be done. Major pancreatic resection are done only if they are locally invasive, anatomically difficult, or high risk patients. Men 1, in short, if it is up to 2 centimeter non-functional, resected. If it's functional, then it has to be resected, but then the dominant lesion is resected in these cases. Medical management may be considered in many cases of gastrinomas. Multicentricity in these hereditary lesions make it surgical decision more complex because, as I told, it is unlikely to eliminate all the disease. So removal of the dominant lesion or the ones that are easily accessible needs to be done. So thereby the main goal is to preserve the pancreatic function. VHL, surgical management on VHL depends on 3 factors. How much is the tumor size, the rate of growth of the tumor, and the germline mutation. If tumor is less than 3 centimeter in size, so the doubling time more than 500 days, and the mutation is outside exon 3, then we can as well observe with serial imaging. But if the size is 3 centimeter or more, doubling time is less than 500 days, and mutation is in exon 3, then we can choose between surgery or surveillance. But if among the three, if there is at least two or more high risk factors, then surgical resection is preferred. So, to compile everything that we've discussed now, case scenarios like if it's a localized non-metastatic, then surgery first is the approach. And when we are doing surgery intraoperatively, if we see a liver met, which is radiologically coupled, this is very rare in present scenario considering the amount of imaging we have right now. So for an upper liver mets, if it's a small volume liver mets, we can do a primary resection and liver mets resection at the same time. But if it is a diffuse liver met, you can just do the primary resection and then plan for PRR. And case 2, where if it is a non-functional less than 2 centimeter incidentally detected, it's an observed. Patient presents with obstructive jaundice, but if it's a small volume distant mets, that case we can do the surgical resection and also liver directed therapies or resection of the liver mets at the same time. In a patient who is known to have a metastatic disease or it is a borderline resectable primary tumor, we first give a systemic therapy along with the somatostatin analog. This is used as a bridge therapy to downstage the tumor and then plan for surgical resection. So if it is an unresectable or large volume extrapancreatic metastatic disease, in that case, systemic treatment. After that, for the liver mets, we give liver-directed therapies. If there is a good response, only then we plan for surgical resection, or else we continue with the systemic treatment. There is an upfront resectable primary tumor and also a resectable liver mets. So in that case, we do the primary tumor resection first. At the same time, if the patient is a stable patient, fit patient, then we can do liver resection in the same sitting. If the patient is not a fit patient, then we can do it as a two-stage procedure. So if it's an unresectable liver mets, especially head of pancreas primary, no obstructive jaundice, but requires ripples. In that case, we give systemic therapy. For the unresectable liver mets, we try the liver-directed therapies. If we see that there is a favorable response in the liver, most of the disease responding to it, then we plan for a Whipple procedure. Now that the main tumor bulk and lot of it has been reduced, then we can use PRRT as a final step modality. The last scenario, patients which are requiring extended surgeries to achieve complete tumor resection in a non-functional NLP. So in these cases, if it's a high-risk patient, high-risk surgery requiring multi-visceral resection, complex vascular resection, but there is significant risk of perioperative morbidity or mortality, it's preferred not to operate in those patients.
So breast में sentinel lymph node के there are 2-3 scenarios. एक है आपका upfront sentinel lymph node dissection, वो negative आया तो क्या करना है, वो positive आया तो क्या करना है, positive में कितना macromets and micromets का, and दूसरा है NACT के बाद sentinel lymph node का false negative rate और उसके applicability क्या है, provided 2 things. पहले नोड नेगेटिव था NACT के पहले एंड अभी NACT के बाद नोड नेगेटिव हो गया है जो पहले पॉजिटिव था. इन सब के एक दो ट्रायल्स अप्रोक्सीमेटली आई थिंक 5-6 ट्रायल्स में इसका मिला के टेक्निक्स ऑफ सेंट्रल नोड मैंने नहीं बनाया अभी तक, तो वो आई डिस्कस सम अदर टाइम.
टेक्निक ऑलरेडी मेरे पास बना है.
हाँ तो वो फिर शेयर कर देना क्योंकि वो ये 2-3 है ना, ये सुपर ऑक्साइड आयरन, ये 2-3 नई चीजें भी आई है तो उनका मुझे पता नहीं है पूछेंगे या नहीं, तो वो मुझे पढ़ना पड़ेगा. ठीक है, सो वी बिगिन फ्रॉम इनिशियल कि पहले ALND था तो उसको SLND कब किया गया. सो वी हैव दी 3 ट्रायल्स, इसमें से इम्पोर्टेंट सिर्फ NAGPP P32 ट्रायल है. बेसिकली इसमें था क्या, 2-3 चीजें हैं. इसलिए आज इन द सेटिंग ऑफ अ क्लिनिकली एंड अल्ट्रासोनोग्राफिकली नेगेटिव एक्सिला, मतलब ब्रेस्ट का जो ट्रिपल असेसमेंट है उसमें क्लिनिकल असेसमेंट में एक्सिला क्लिनिक रेडियोलॉजिकली नेगेटिव है. So and the breast cancer is early, मतलब it is T1 or T2 ideally. SLND is the standard procedure of choice. ये कैसे आया, ये 3 ट्रायल से आया, मिलान, NSGPP P32 and Albanet ट्रायल. ये जो 2 ट्रायल्स थे वो मल्टी सेंट्रिक थे एंड हर एक में उन्होंने सेंट्रल लिम्फ नोड किया फॉलोड बाय एक्सिलरी लिम्फ नोड डिसेक्शन किया एंड दे फाउंड दैट द फॉल्स नेगेटिव रेट्स वर अफेक्टेड बाय द नंबर ऑफ नोड्स रिट्रीव्ड. और अगर 2 या 2 से ज्यादा नोड रिट्रीव करे तो फॉल्स नेगेटिव रेट लेस देन 7% था. सबसे बड़ा ट्रायल इसका B32 था. SLN डिटेक्शन रेट was in all these three trials close to 97, 97, 97, 98. बेसिकली ये तीनों ट्रायल का मिला के ये था कि सारा स्टैंडर्डाइजेशन में रूटीन जनरल पॉपुलेशन रिप्रेजेंट हो गई थी बिकॉज यू हैड पेशेंट्स ऑफ ऑल एज, साइज ऑफ द प्राइमरी, ब्रेस्ट का ट्यूमर का साइज, ब्रेस्ट का सर्जरी का टाइप. Important was these trials did not address the T4 tumors and the inflammatory breast carcinoma. NSGPP B32 main discuss करना है. So the population of this trial was, with over a period of 6 years, recruitment was approximately 5,600 patients. It was a multi-centric study. The females had tumors which were segregated according to size, less than 2, 2 to 4, and more than 4. Surgery performed was lumpectomy and mastectomy both. So population was 5,000 plus patients. These guys segregated according to this. Lumpectomy, mastectomy दोनों हुआ था. That was the population. What was the randomization? The randomization was one group underwent sentinel lymph node biopsy followed by axillary dissection, क्योंकि अभी इसमें ही आपको false negative rate मिलेगा. And the other group was sentinel lymph node biopsy alone. That alone मतलब it did not move on to axilla if the node was negative. So the control arm was this, कि node negative हो या positive हो फर्क नहीं पड़ता, हम axilla करने ही वाले हैं. And the intervention arm was this. The primary outcome was overall survival. So at a median recurrence of approximately 6 years, I think, उसके बाद it was proven at 10 years also. What they found was that overall survival did not affect. The overall survival was non-inferior in both, 91% in the ones that underwent axillary dissection even when the sentinel node was negative, and 90% who did not undergo axillary dissection if the sentinel node was negative. So sentinel node negative है तो axilla का dissection करो या नहीं करो, survival did not change. उसके अलावा even the loco-regional recurrence rates were similar in both groups. So basically what the authors found was overall survival, which was the primary outcome, DFS and LRR secondary outcomes. In patients with a negative SLNB, whether they undergo ALND or they don't undergo ALND, all these things are safe. So ALND में morbidity add होता है, कोई survival advantage या loco-regional recurrence का advantage नहीं if the SLNB is negative. So Almanac trial ये सिर्फ NCCN में इतना 4 लाइन दिया था, इससे लिखा है, but main they asked the B32 trial if they asked. हाँ, more than that, the sentinel lymph nodes detected were उन्होंने जो double dye technique use किया था, the blue dye used was isosulfan blue injected 5 minutes before the skin incision, and the sulfur colloid was technetium 99 intradermal injection 3 minutes to 8 hours before the surgery depending on the institute protocol, क्योंकि multi institutional study था. ठीक है, so NSABP 32 basically proved कि अगर sentinel node negative है and sentinel node detection rate was approximately 97%, so and false negative rate was also less than 7% if the nodes removed were more than or equal to 2 and dual tracer method was used. Dual tracer method का principle वही है, more than 10% जिसका radioactivity है उसको निकालना and सारी blue nodes को निकालना. So ये आपका NSABP B2 था, B32. So then came the role कि अगर SLNB पॉजिटिव है उस केस में एक्सिला करना है या नहीं है. तो उसके लिए we have these two trials. दोनों ने दो अलग अलग चीजें प्रूव करी. So the Z11 trial basically said उसका population था 800 patients, T1 और T2 मतलब less than 5 centimeter. Patients underwent BCT. ये important है, याद रखना. Patients का mastectomy नहीं हुआ था. यहाँ पे हर patient का BCT हुआ था. इसका मतलब हर patient का BCT हुआ था, उसके बाद उसको radiation मिला था. ये चीज important है. So T1, T2 tumors who underwent BCT, T means therapy. So BCT के lumpectomy के बाद उनको radiation मिला था. And the SLNs that were considered were 1 or 2 nodes positive. अगर इतना किया तो randomization intra-op हुआ. Intra-op मतलब patients were intended to undergo radiotherapy. So T1, T2 tumors, clinical radiologically node negative, 1 और 2 पॉजिटिव lymph nodes इंट्राऑप, उनका रैंडमाइजेशन हुआ कि कंट्रोल आर्म वाज एक्सिलर lymph node डिसेक्शन किया एंड इंटरवेंशन आर्म वाज एक्सिलर lymph node डिसेक्शन स्किप किया. तो सेंटिनल lymph node डिसेक्शन ओनली 400 patients. Overall survival was the first, that is the primary outcome. Difference नहीं था 91, 92. Wider disease survival also similar 82, 83. Local regional and axillary recurrence also similar 80, 1.8, 3.6, 0.5, 0.9. No, not significant. So Z11 basically wanted to find whether there was a difference in OS or LLR in early breast cancer T1, T2 with 1 or 2 positive sentinel lymph nodes who underwent just sentinel lymph node dissection versus full ALND on this finding. Which is important that now patients were excluded if they had received NACT or if they had gross extranodal extension. Clinico-radiologically negative थे, but इंट्राऑप अगर तुमको लग रहा है ग्रॉस एक्सटर्नल एक्सटेंशन है या ऑपरेटेड या मैटेड नोड्स है, मतलब T2 था, तो उसको एक्सक्लूड किया बिकॉज वी आर जस्ट लुकिंग एट सेंटिनल नोड्स, नॉट ऑब्वियस इन्वॉल्व्ड नोड्स. ALND जो था it was level 1 or 2 and it was done like I said 1 or 2 nodes SLND पॉजिटिव था, मतलब सेंटिनल lymph nodes 1 और 2 पॉजिटिव, तो ही हमने ये रैंडमाइजेशन किया. अगर 3 नोड पॉजिटिव आ गए तो आप ALND कर रहे हैं, वो ये ट्रायल में इंक्लूड नहीं होगा. All patients by protocol received adjuvant whole breast radiotherapy by protocol because it was breast conservation. Axillary radiotherapy was avoided in all patients, so we did not treat the axilla. We just had SLNB, and जिनको 2 नोड नेगेटिव, जिनको 2 नोड आया पॉजिटिव, उसका अगर ALND अवॉइड किया है तो उसको रेडिएट भी नहीं किया है एक्सिला को. सो एक्सिलरी ट्रीटमेंट.
पर इसका कुछ टेंजेंशियल फील्ड का कुछ इशू था जो इसका नेगेटिव उसका क्रिटिक्स था ना.
बताऊंगा.
लैटरल रेडिएशन गया है एक्सिला को जो DCT वाले पेशेंट्स हैं.
हाँ, वो 16% को गया था, बट बेसिकली एक्सिला को रेडिएट नहीं किया था. टेंजेंशियल रेडिएशन जाता है वो अलग है, बट एक्सिला को रेडिएट नहीं किया था. तो
ऑल्सो इनमें 80% कुछ हार्मोन पॉजिटिव ट्यूमर्स थे, ट्रिपल नेगेटिव और HER2 का कोई ज्यादा रिप्रेजेंटेशन नहीं था. One question, you're saying even the ALND ones didn't undergo axillary radiotherapy, right? Like neither arm got any.
Yes. All patients were underwent lumpectomy followed by whole breast radiotherapy, avoiding axilla. So जो भी axilla को radiation मिला, it was basically tangential. So all that was same. फर्स्ट एक्सिला में इतना ही फर्क था, एक का सेंटिनल लिम्फ नोड बायोप्सी हुआ और एक का एक्सिलरी लिम्फ नोड क्लियरेंस हुआ. दैट क्लियरेंस वाज लेवल 1 and 2 only. So they showed a 6.5 year follow-up जिसमें locoregional recurrence and overall survival was not different in both the groups. So the result was women with a positive SLN, positive means 1 or 2 nodes only, clinical T1, T2, undergoing lumpectomy with RT. This is very important. Followed by systemic therapy. मतलब basically पूरा BCT का protocol. Do not benefit from the addition of ALND in terms of locoregional control, DFS or OS. The only additional information in these patients gained from ALND is the number of nodes. That's it, which is technically prognostic, but no survival benefit. Now there was a lot of criticism for this. There were 4 criticisms. पहला था its accrual was altered early due to lower than expected accrual, and तो एक ये criticism. दूसरा था 18% of patients received off protocol axillary RT, which some argued may have led to better local control. Third था 6.5 year median overall survival was very less क्योंकि ER positive tumors tend to recur even beyond 5 years. Actually, I don't know, 5 years हम लोग यूजुअली 10 साल के बाद या कहीं तो मैंने पढ़ा था. So even beyond 5 years they tend to recur. So 6.5 year follow-up was not adequate ऐसा criticism था. And finally some criticized that patients younger than 50 years old and TNBC tumors were underrepresented. So all this was a criticism, but even at 10 year survival their findings were reproduced. So ठीक है, मतलब at least a couple of criticisms were dealt with. So this was the Z11 which said कि अगर macromets SLN positive up to 2 SLNs positive could be patients could be avoid axillary lymph node dissection. What about the micromets? Obviously बात है, if you do this, तो macromets अगर problem create नहीं कर रहे हैं तो micromets problem create नहीं करेंगे. But we have another trial for this. इसके भी ऊपर से advantages different थे. So the IBCG International Breast Cancer Study Group. I am just on sidetracking a little. I have this habit कि मैं ये मतलब even if I write the short form, usually I do either say it or have it in the document somewhere. कि इसका एब्रीवेशन का फुल फॉर्म क्या है, क्योंकि हमारे सीनियर्स एज इन हमारे लेक्चरर्स सब पूछते हैं कि इसका फुल फॉर्म बताओ, इसका फुल फॉर्म बताओ. आई डोंट नो हाउ इम्पोर्टेंट दैट इज इन द एग्जाम, बट आई गेस वी शुड नो. सो ओवर 900 पेशेंट्स, अगेन T1 T2, इनका जब सेंटिनल लिम्फ नोड डिसेक्शन किया तो दे इंक्लूडेड ओनली माइक्रोमेट्स and the patients could have undergone both BCS or mastectomy. So this was one difference. Micromets be include kiye, and second, patients were allowed to undergo mastectomy as well. Now 2001 से 2010 का इसका ये था recruitment था. 2005 में the inclusion criteria broadened. They included patients with more than one positive lymph node also, जैसे Z11 का था. Plus, they included multicentric and multifocal tumors also. This was important. ये Z11 में नहीं था. And any microstatic focus of less than 2 mm was included as isolated tumor cell. So ये तीन चीजें थी जो technically separate था from Z11. Most patients had 1 to 2 nodes involved and were randomized to either ALND or nothing, like it was done in Z11. And patients who underwent BCS obviously received adjuvant breast radiotherapy also. What they basically said was the study demonstrated non-inferiority of slnb again as compared to ALND in patients with micromets and isolated tumor cells with regard to local recurrence TFS in OS. So findings, our outcomes as far as principle is concerned, the outcome was same as the Z11, but all I wanted to basically highlight is this trial included multicentric tumors and lesions of up to size 5 cm. But just like Z11 में आपके under than 50 years of age and PNBCs were underrepresented, यहाँ पर भी most of the patients, 92% of the patients have lesions just up to 3 cm, which is technically T2, but it is low T2. And were treated with breast conservation. So mastectomy group was a little underrepresented here. So basically in dono, both Z11 and ये अपना IBCSG, both of them together taken, multicentric IBCSG ने basically ये भी prove किया कि multicentric and multifocal tumors के अंदर भी आप sentinel lymph node biopsy कर सकते हैं. The false negative rate is appreciable. It's less than 10%, provided वही 2 से ज़्यादा nodes निकाल रहे हो and dual tracer use कर रहे हो. In this scenario, even in multicentric or multifocal tumors, sentinel lymph node biopsy can be done, is applicable. ये trial में ये main important था. बाकी micrometastatic ठीक है, but this was also important. So then came the AMROS trial. AMROS trial ने basically ये बोला कि अभी तक so first we began with the idea कि अगर sentinel lymph node negative है, so can we avoid axillary clearance? So that was proved by the B32 trial. Then came the idea कि अगर sentinel lymph node positive है, can you avoid the axilla? That was 2 trials. It's a Z11 trial which said कि 2 या 2 से कम node positive है तो आप avoid कर सकते हो, provided T1 T2 tumor है, BCS हो रहा है, मतलब पेशेंट को रेडिएशन एंड कीमोथेरेपी दोनों मिलने वाला है. In that case you can avoid. In this case only came the IBCSG trial which said कि micromets के अंदर भी आप avoid कर सकते हो. Over and above that आप mastectomy के cases में भी sentinel lymph node करके radiation avoid कर सकते हो. Over and above that आप multicentric tumor and multifocal tumors के अंदर भी आप sentinel lymph node कर सकते हो. Then came the AMROS trial which basically tried to prove instead of clearing the axilla, can you give radiation to the axilla? So in all indications where the axilla needs to be cleared, can you avoid this and give radiation instead? So इसमें the population was, it was a multicentric study, 4,800 patients. इसमें से यहाँ पे you can see approximately 680 and 744. So that's approximately what, 1500-1400 patients. So 2000 assigned to axillary lymph node dissection, 2000 assigned to axillary radiotherapy. उसमें से जिनका सेंटिनल लिम्फ नोड नेगेटिव आया सबको एक्सक्लूड कर दिया. तो जिनका सेंट्रल लिम्फ नोड पॉजिटिव आया, मतलब जिसके अंदर एक्सिलरी लिम्फ नोड डिसेक्शन वाज इंडिकेटेड, इन दोस दे बेसिकली रैंडमाइज्ड. Randomization was patients included for either axillary lymph node dissection or patients included for axillary radiotherapy. So they found the 5-year local recurrence, which was the primary outcome, and the recurrence-free survival, overall survival post-procedure. Sorry, overall survival was, I think, the primary outcome. So, though multifocal tumors had a higher SLN METs rate, absolute rate, than the unifocal, further nodal involvement was similar in both the groups. मतलब वही, तो आपका basically सेंटिनल का concept है कि अगर SLN negative है, तो ALN की जरूरत नहीं है. That held true. But यहाँ पर भी, like in the AMAROS trial, यहाँ पर भी multifocal tumors में sentinel lymph node dissection is feasible. ये prove किया उन्होंने.
एम्ब्रोस का
You can see, ये एक टेबल है. An increase in the arm circumference by at least 10% was reported numerically in a greater proportion of patients in the lymph node dissection group compared with the RT group. However, the difference was only significant at 5 years. So, अभी तक जो अपन ने पढ़ा, we studied 4 trials, B32, IVCSG trial, Z11 trial, and the AMAROS trial.
एम्ब्रोस में पर कॉन्ट्रालेटरल ब्रेस्ट में कैंसर के चांसेस बढ़े थे, आई थिंक. Breast cancer.
पढ़ा नहीं, but हो सकता है. I don't think I've gone through the entire paper yet.
ये किए था मैंने अपने जो प्रेजेंटेशन में प्रेजेंट किया था ना, उसमें कॉन्ट्रालेटरल ब्रेस्ट कैंसर के चांसेस बढ़े थे. दैट्स व्हाई हम लोग अभी वो स्टैंडर्ड नहीं हुआ.
How come? कुछ रीजन?
कम की नहीं, मुझे नहीं पता.
एक बार ग्रुप पे टाइप कर देना, तो आई जस्ट रीड द आई हैव द पेपर, आई थिंक. तो मैं एक बार पढ़ के देख लूं.
ओके.
सो अभी तक से करना चाहिए, बट द अंडर एस्टिमेशन रिस्क कैन नॉट सिंक टू जीरो. दैट इज व्हाट दे हैव रिटन. सो करंटली अपफ्रंट SLND is performed in high risk features for underlying invasion, which I haven't seen in my 2.5 years कि कभी किसी पैथोलॉजिस्ट ने DCIS में कमिडो नेक्रोसिस करते हैं वो लोग रिपोर्ट, बट ये नहीं रिपोर्ट करते कि हाई रिस्क फीचर्स ऑफ अंडरलाइंग इन्वेजन. बट क्लिनिकली वी डू हैव दीस फीचर्स दैट से दिस.
हमारे यहाँ आया है.
आया है क्या वैक्यूम असिस्टेड आया? ये
वैक्यूम असिस्टेड नहीं, हमने एक्सीजन बायोप्सी किया था, उसमें वो इन्वेजिव आ गया.
अच्छा. एंड हाँ, ये तो करना ही, मास्टेक्टोमी कर रहे हो अगर DCIS के लिए, तो उसके लिए तो SLND करना है, क्योंकि उसके बाद योर पाथवेज आर डिस्ट्रॉयड. And secondly, this in our institute we usually do practice, but there is only observational data. Omitting SLND in older patients, frail old patients with small T1, T2 tumors, hormone receptor positive, who are usually undergo BCS only, जिसमें हम अगर पेशेंट को नहीं है इतना वो, तो हम लोग RT भी नहीं देते हैं, we just give hormone therapy. तो उसमें SLND करने का मतलब नहीं है ऐसा. There is observational data, but there is no hardcore data. And ये एक important है. मेल ब्रेस्ट कैंसर में SLND का रोल फॉर्मली वैलिडेट कोई RCT में नहीं हुआ, क्योंकि वेरी फ्रैंकली मेल ब्रेस्ट कैंसर इज यूजुअली प्रेजेंट इन लोकली एडवांस्ड.
Now, upper outer quadrant. If DCI is in upper outer quadrant, female, then is there like something you have read? We should do SLNB or not?
Have to do और क्या?
should ना.
हाँ.
should.
पोस्ट NACT का नेक्स्ट टर्म करो ना, कंफ्यूज हो जाएंगे सब.
ठीक, तो अभी 4 ही ट्रायल करे अपन ने.
4 ही करते हैं, फिर 4 बाद में रिवाइज कर लेंगे.